Good evening, everyone, and thank you for joining me tonight for my fourth Fertility Live. Tonight I am very, very lucky to be joined by the renowned fertility specialist, Dr. Lynn Burmeister, who is the owner and medical director of Number One Fertility. And tonight we're going to talk you through what actually happens during an IVF cycle. We're going to take you through the process step by step. Now, as an obstetrician who's been through IVF myself with my wife, I think I have a pretty good professional and personal understanding of what IVF involves. But for couples struggling with fertility, I think the thought of IVF can actually be a very overwhelming one for a lot of people. So we're very, very lucky that Lynn has agreed to join us tonight, and we'll talk you through the process now. So I'm just going to get Lynn, and we'll start shortly. Good evening, Lynn. How are you?
Hi, Scott. How are you?
I'm very well,
I was
thank
going to
you.
join you or you were going to join me.
We got there eventually, my friend. How are you?
Very well. How are you?
I'm well, thank you. I suspect you've had a busy couple of weeks now that IVF's been able to recommence in Melbourne.
Yeah, it's been very, very busy. So just like building all the sort of angst and the sort of stopping within that very short time, and then all the angst between the patients and trying to calm them all down, saying, yes, a couple of months will be fine, don't wait, don't worry. And then all of a sudden, within 3 weeks, we're back up and running. So
absolutely,
we've got a lot of patients over the last few weeks.
Definitely. And I know, for a lot of people going through fertility journeys, it can be stressful enough at the best of times. So this has really probably thrown a lot of people out a little bit. But that's why I thought what we're going to talk about tonight would be really useful for a lot of people. I think the concept of IVF, for a lot of people who don't really know what to expect, can be a very, very daunting one. And I thought just sort of taking people through the process in a step-by-step fashion would be really, really useful. So thank you for joining me tonight to help me do that for our viewers.
No problem.
Excellent. So what I thought we could start with, Lynn, is putting a scenario to you. So you've got a couple who are coming to see you with infertility, and you've done your initial consultations, and you've decided with the couple that the best sort of process for them will be IVF in order to give them the best chance of getting pregnant. They've done all the paperwork, they're sort of ready to go. And the first bit then is to sort of help a woman to create a number of eggs through controlled ovarian hyperstimulation. So can you talk us through what that actually means and what it involves?
Yes, so once they've completed all their paperwork, which in Victoria is enormous, including police check, child protection, counselling that you have to do in Victoria, and then finally you get to meet the nurse who will go over the medication the doctor has prescribed. Yes. And that is usually an injection. It might be 2 different injections, it might be 1 injection, and usually you start that injection on day 2 or day 3. And then by about day 6 or day 7, you might start another injection to stop you from ovulating. Yep. You might have a scan around day 6 or 7. If your doctor's worried you might be overstimulating, and so you'll have an early scan. So it's 2 daily injections from about day 6 or 7, and then by day 9 or 10, you'll have your final scan. Yep. And then by the time your final scan's there, the doctor will work out whether you're ready to have your egg collection or not. And that might actually happen around day 13 or 14 of your cycle. Day 1 is the first day of your cycle. Yep. And so that might happen around day 13, 14, but it actually might be longer. It might be day 17, 18, because ideally we want the follicles to be around 22 millimeters, 20 millimeters, 90 millimeters. So we want them quite big to get mature eggs from them.
Right, not a problem at all. And a lot of women have sent messages into me saying what sort of symptoms or side effects can they expect with the injections that you prescribe sort of to create the eggs?
So as they're taking the injections, a lot of patients say to me, oh, doctor, am I going to put on weight? Well, I always say, my answer is, well, you'll put on more weight when you're pregnant. Yes. But the side effects will be bloating. Yeah. So definitely bloating. You might feel hungry. So you might get moody, your boobs might get sore, your stomach will get swollen, you won't fit into your jeans. So you'll have those symptoms leading up to the egg collection, but sometimes they actually become worse after the egg collection, and that can be associated with hyperstimulation syndrome.
Right, and that was actually going to be my next question to you. What sort of is hyperstimulation syndrome in a sort of a lay terms, and what can you do to try and prevent it from happening?
So the ovaries are all being hyperstimulated. So in the fact that everyone is actually being hyperstimulated in a way. So even if you get 3 eggs, 4 eggs, 5 eggs, you're still being hyperstimulated. So I've had some patients with low egg numbers still feel that they're hyperstimulated. So in a way, all IVF patients get hyperstimulated. But some patients actually get the severe form. It doesn't happen very often. 20% of the patients will complain of a moderate hyperstimulation syndrome, but about 0.5 to 1% of patients will complain of a severe hyperstimulation. And that's where their ovaries can grow to the size of a basketball. And they can produce a factor called VEGF, which is a vasodilator, and it dilates all the blood vessels. And then so your fluid that's circulating around in your blood vessels actually goes into your third space. So it builds up into your abdomen and it builds up into your chest wall. And so that's severe form of hyperstimulation syndrome. And so some patients will develop that. It is very rare. And we do try and avoid it by titrating the doses very carefully. And also now we usually give a GnRH agonist, which is a different type of trigger, which actually avoids the syndrome. So we do give that a lot if we think that a patient is going to be at risk of that.
Not a problem. And talking about the trigger sort of moves me on to the next question that I was going to ask you about. How do you prepare the follicles for egg collection?
So the follicles take 3 months before you start your period to actually be prepared. So I always tell my patients, okay, healthy lifestyle, healthy diet, take your vitamins. I pile my patients up with a whole heap of antioxidants. So I'm very, stop smoking, cut down your coffee, cut down your alcohol. So that's my initial preparation. And then the next preparation is the injection phase. And so as a doctor, to look at what I'm going to prescribe the patient, I actually look at their weight. I look at how many follicles they have in their ovaries, and also their anti-Müllerian hormone, which is like the egg bank test. So I look at all those 3 things, and then I sort of work out what dose I'm going to give that patient. And then that's how I prepare the follicles. I usually do like to give a little bit of LH support within the FSH medicine that I give. I always give a combination of medicine. So most of my patients will, at the end of their cycle, be on 3 different injections, and that's not because I'm trying to be mean. That's just because I'm trying to get better eggs off my patients.
Definitely. And what's the role of the trigger that you give them just prior to the egg collection?
So the role of the trigger, there's there's 2 types of traditional triggers. There's Ovidrel and Pregnal. So Ovidrel is a recombinant technology, and Pregnal is the older form, which is the HCG. I tend to give Pregnal because I feel it matures more eggs. And I feel that we do get more eggs when we give Pregnal, even though it is a bit more of an awkward injection. So there's 2 types of the traditional triggers, and they do cause hyperstimulation syndrome. So they can be associated with the severe form. I have moved a lot of my patients onto the GnRH agonist, which is using Cineral or Decapeptyl. So a lot of my patients will be on a different form of trigger, which works a little bit different. So that form of trigger actually goes to the brain to spark a natural LH surge, which will then mature the eggs. And with those triggers, we don't have the risk of severe hyperstimulation syndrome. And so a lot of my egg freeze patients will use that trigger. However, my IVF patients, where they're planning to put an embryo back, can't use that trigger. Because if you use an agonist trigger, what happens is all the hormones fall away and patients get their periods very quickly. So we can't put an embryo back on an agonist trigger.
That makes sense. Perfect. And then after a patient has taken the trigger injection, how long afterwards do you generally do a collection? And can you talk our viewers through what an egg collection actually involves?
Yeah, so after the traditional trigger, like pregnal or epidural, the egg collection is usually done 36 hours later. Sometimes I might extend that trigger if a patient's had a history of immature eggs. So I might say, okay, next egg collection, we're going to do the trigger at 38 hours to let them mature inside you a bit longer. So once the trigger's done, we then go and collect the eggs. And now a lot of patients will panic because they think it's 36 hours, I have to go into theatre at 36 hours. That's actually not the case. You've actually got 2 hours either side. So even with a 38-hour trigger, you can actually collect the eggs 2 hours later without the patient ovulating. So there is room, so please don't be stressed if your doctor's running late and say your egg collection 37 hours rather than 36 hours. So
that's very reassuring, because I have had quite a few women ask that exact question. How sort of precise do we have to be in terms of the timing? So that's good to know.
I think we're like, very focused on timing. Like we tell the patient, you must take your antagonist in the morning at 7 o'clock every morning or 7 o'clock at night. And actually it really doesn't matter as long as I get it in that day. But the trigger does matter. But the trigger, it doesn't really matter if your doctor collects your eggs 35 hours, or 37 hours or 38 hours. It really, that doesn't matter. So you're not going to ovulate within a couple of hours. So you've got a little bit of leeway if your doctor is running late for doing your egg collection or even running early.
Brilliant. And for a woman who shows up on the day for her egg collection, what will the day look like for her?
So what the day will look like, we don't want you to have any breakfast. Depending on what time your egg collection is, your doctor might say you can have some water. And so you'll be admitted. And most clinics will do their egg collections under sedation. Some clinics do their egg collections under local anaesthetic, which is perfectly fine as well. But most clinics will do their egg collection under sedation. So you'll be admitted, you'll be put in a gown, you'll be taken to theatre, you'll have a nice anaesthetist checking you in, and you'll have an embryologist who will go through your consent form to ask you, okay, well, when your eggs are collected, you signed off that you want standard insemination, which is where you just want the eggs and sperm put together, or you signed off that you want ICSI, which is where you want the sperm and eggs. So the scientists will go through the final questions. They'll also do a double check of your name. They'll also do a check outside the theatre, and they'll also do a check within the theatre, along with what we call a timeout in theatre before you go off to sleep. And then you'll go off to a sedation anaesthetic, which is a very nice anaesthetic. You won't feel or remember the egg collection. And the egg collection usually takes about 10 to 15, sometimes 20 minutes, depending on how many eggs are needed, are collected.
It's quite quick, isn't it?
Yeah, and so we collect the eggs through the vagina with an ultrasound. And it's a usually very simple procedure where the needle just passes through the vagina and drains the follicle. And then that egg goes into a warmed test tube. So the test tubes are warmed. It's taken straight to the lab. And as we're collecting the eggs as IVF doctors, the embryologist is yelling out to us, 1 egg, 2 egg, 3 eggs, 4 eggs, 5 eggs. So every time we're collecting an egg, we get feedback about whether we're collecting the eggs or not.
And when will the patient find out how many eggs you've collected?
So the patient will find out in recovery. So with my patients, I wait one case. So I'll do the case, collect that patient's eggs, then I'll start the next case, and then I'll go out before she ends up in the second stage of recovery, and I'll go out with her egg sheet because she's very brilliant. They are very keen to find out how many eggs they have. So I usually go out before they reach the second phase. And so within half an hour, they'll know how many eggs they've got collected.
Fantastic. And in terms of the sperm collection that needs to occur sort of relatively simultaneously, what does that involve for the male partner?
So on the same day, the partner will go to the IVF lab to produce a sample. So that sample's done. So what will often happen is they'll drop their partner off and then they'll go off and produce a sperm sample. Some men get very anxious about that, and we've had some men in the past that can't produce a sample. If we think that the partner is going to be anxious, we advise that they freeze some sperm before.
Perfect, excellent. And then the embryologist obviously then has the eggs and the sperm, and they then try to culture them essentially. So just in terms of standard IVF versus ICSI, which you spoke about before when you were talking about the embryologist doing the consent, when do you decide which one should be done and how do they differ?
Well, I do like to do standard, which is where we just put the eggs and sperm together.
Yes.
So I actually prefer that as a technique to fertilize the eggs because I think it's healthy for the eggs.
Right.
But some people do need ICSI. So if there is true male factor where there might be abnormalities in the sperm, so the shape of the sperm might be abnormal and you think that the sperm's not going to get into the egg because of the shape. Also, some men might have very low volume, so they actually might have very low concentration of their sperm. Right. And so less than 5 million sperm, even though 5 million sounds amazing, that's actually low. Yeah. So less than 5 million, you would probably suggest that patient has ICSI. Not a problem. And if the sperm's swimming really slow, so if its motility is really low, you might suggest ICSI as well, which is where we put the sperm into the egg.
Brilliant. And once that's occurred, how long are the embryos cultured in the lab for, ideally before you either do your fresh transfer or you freeze them?
Yeah, so the next day the scientists will come in and see if your eggs and sperm have fertilized. So what they're looking is a 2PN embryo where there's little polar bodies within the pronuclei within the egg. So looking for two pronuclei within the egg, which they can see through, we've got embryoscopes, so they'll actually look for that. They'll see a polar body outside the egg, and they'll see whether your egg is fertilized or not. And so that's the next day. So we expect the pronuclei to be there the next day. So by day 2, we expect a 2 to 4 cell embryo. And then by day 3, we expect a 6 to 8 cell embryo. And then on day 4, the embryo starts to undergo compaction, where all the cells start to look like they're one. So it goes from being an 8-cell embryo into a 60-cell, 80-cell embryo, and all the cells start to join together. And that's the very vital stage called compaction. If your embryo doesn't go under compaction, then it's not going to go into the next stage, which is blastocyst, which most clinics are now transferring the embryos of blastocyst, because blastocyst is the day 5 embryo, which has 80 to 100 to 120 cells, and it's actually at that stage where it's telling us whether it can be a baby or not. Whereas the early embryos at day 3 or even day 2, where we used to transfer 20 years ago, they're not really telling us whether they can progress on to be an embryo or not.
Absolutely. I think from my experience, a lot of couples undergoing IVF are sort of quite fixated on the number of embryos that make it to day 2 and then day 5. As a sort of general rule, or not even a rule, but what you're hoping for your patients, what sort of numbers are you hoping will make it to day 2 and then successively to day 5?
So let's take, for example, we've collected 15 eggs, which is a great result.
Fantastic.
So 15 eggs, perfect. So we've got 15 eggs, and then we go back to the lab and we do natural insemination, which is putting the eggs and sperm together. Then we would expect the next day, the sperm and eggs are working well together, we would expect a 60 to 70% fertilization. Right. So we're 15, now we're down to maybe 11 eggs that are fertilized. So by day 3 then, we'd look again and see what's going on. And by day 3, we would expect to see probably by that stage about 8 embryos sitting there. That would be what we would expect. And then by day 5, we would then expect 2 to 3 embryos from that sort of collection.
Absolutely. So I've seen couples before.
So if you have, I usually say to patients, if you've got 11 to 12 fertilized eggs, we would expect 3 blastocysts.
Perfect. That's good to know, because I think a lot of couples think they're going to get much higher numbers based on the initial egg collection number. So it's very sort of reassuring, I think, for a lot of couples to know that even if they get 2 or 3 at the end, it's a great result for the cycle.
And there is a huge drop-off, and that's because your embryos are sorting themselves out. So the embryos that don't get to blastocysts are usually chromosomally abnormal.
Not a problem at all. And when the embryos are cultured and we're getting towards the stage of the sort of the embryo transfer, which I'll talk to you about shortly, how do the embryologists, you know, in conjunction with the fertility specialists like you, decide which one's the best one to go back in? What are you looking for?
So we're looking for how it's developed from a very early stage as well.
Right.
And so the scientists will look right through, and that's why it's so good to have the embryoscopes where they'll actually look at the video or the time lapse of that embryo. And they've actually got a kid's score built into them, which actually scores the embryo as well. And then you've got the scientist who's very experienced as well, who scores the embryos like a AA, AB, BB, CC. So you'll get a score from the embryologist, you'll get the kid's score, and we've got Life Whisperer, which is artificial intelligence, which gives us another score.
Fantastic.
So there's different scores. The scientists, I think, will mostly make the decision based on all the information they have. But you can, when you look at the embryos, you can actually see a difference between some of them, and the scientists with their experience will pick out the best one for transfer.
Great. Excellent.
We do actually think freezing embryos is probably better. It's just getting the patient's mindset into, okay, freezing is better, is probably safer for you, and the pregnancy rates are actually better with a frozen embryo. But changing the mindset of the patient is actually quite difficult.
Definitely. I think a lot of them are on the sort of journey already and they just want it done as quickly as possible so for them a fresh transfer. Absolutely, definitely. So moving on to the transfer now, when do you ideally transfer the embryo, and what, again, does this day look like for a woman or couple who come for their transfer?
So that's a really exciting day. So it's not so exciting now because we can't have the gentleman along, but hopefully bans will be lifted soon.
Not too long.
But it's a really exciting day, and we try to treat our patients really like they're princesses. And so they come into our clinic, they lie down in our chaise lounges, and
they're pampered for the day.
And I usually advise patients to take the morning off, or the afternoon off, whenever their transfer is, and try and do something nice that day. And a lot of patients will do acupuncture pre or post, or they might have a massage. When we can go back to massages or facials, or they'll try and do something nice for that morning or afternoon whenever their transfer is scheduled. So they come into the clinic, and the embryologist will speak to them about their embryos. And in our clinic, we show them a video of their embryos, and they get to keep their video of their embryo. And then they get put into a transfer room. The embryologist will come in again to double check that the person is who they're putting the embryo in, so that everything's double checked, triple checked. Everything's witnessed, and the doctor will also witness the patient as well. And then the patient usually comes in with a full bladder. So we like you to come in with a full bladder because we put an ultrasound on top of your stomach or on top of your abdomen to visualize the uterus. And so we can see that better with the full bladder. So we have a transfer nurse who puts the ultrasound on the lower abdomen, and then with a speculum, just like having a pap smear, we have a tiny little catheter that passes through the cervix. It shouldn't cause any pain. And then once we've loaded the catheter into the cervix, we ask for the embryo, and then the embryo is brought in by the embryologist. And the embryo is put into the middle of the uterus. So we have like specific points where we want to see that embryo land, and the embryo goes in with a little tiny bubble. So at the start of the catheter, there's a little tiny bubble, and then the embryo, and then another bubble at the end after the embryo. Because when we're putting the catheter through the cervix, we don't want to lose the embryo. So it always goes in with a little bubble so the embryo doesn't fall out of the catheter. We get the embryo into the middle of the uterus, and then we tell the scientist to put the embryo in. So it's sort of a combined treatment protocol and a combined team effort to get that embryo back into the patient.
Brilliant. And once the embryo has been transferred, what do you tell your patients to do for the rest of the day? I know there are, a lot of women who say, I'm just going to go home and lie in my bed with my legs up and try and get everything to take, but there's certainly not much evidence for that, is there?
No, there's no evidence to lie in your bed and you can go back to work. If you feel that work is the thing for you and that makes you relaxed, then you can go back to work. You can go for a walk around the park. You do not need to lie down. I know a lot of patients stress that they need to lie down and not go to work or not move, but you can go back to normal activity. We just advise you not to do high impact exercise where your pulse is going to get very high. But apart from that, you can go back and do normal activity.
Brilliant. And how long after the transfer can a woman or couple expect to find out whether or not it's been successful?
So within the, so you're up to now day 5 where you're putting the embryo in. So within the next 10 days, you'll be able to find. And I know a lot of patients will do pregnancy tests. So they'll go and buy, I've seen like Instagram posts where people have done they've bought like 50 pregnancy tests, and I'm like, oh wow. So you don't need to do that. And a lot of the doctors, because you remember you've taken the pregnancy hormone to release the eggs. So if you do a pregnancy test 2 days after your embryo transfer, it is actually going to show up positive. And then you'll be all excited that you're pregnant. But it might be just a trigger injection.
Of course.
And then some doctors also prescribe pregnancy hormone in the second phase of your embryo transfer. So I've had patients say, oh, I did my pregnancy test and it was all positive, and I didn't know that the injection that I was getting was actually making me, making that pregnancy test positive. So it's not a good idea to do the pregnancy tests early. Because pregnancy tests will usually only show up if the beta-HCG is around 50. And so you might get yourself very disappointed early if it's negative. So the embryo will take about 3-4 days to implant after we've put it in. And then you've just got to be patient and wait for your pregnancy test, which is about 10 days after your transfer.
Perfect. That's a blood test for the woman who's had the transfer.
So a blood test for pregnancy hormone and your progesterone level.
Perfect. And do a lot of women need luteal phase support, so progesterone, between the transfer and the blood test being done, and then early into the pregnancy as well? Yeah,
so after an egg collection you do, because even though you've got a lot of, so what happens after the eggs are collected, those follicles that we've collected the eggs out of then become cysts, and they're called corpus luteum cysts. But a lot of them don't produce the progesterone the way we want them to after an egg collection. So after an egg collection, you will need extra progesterone support. And so your doctor might give you 1 progesterone pessary, which is vaginally. They might give you 3. Every doctor varies in what they give their patients. Some doctors will even give progesterone injections as well. So every doctor will differ, and that depends on your case story as well. If your progesterone is really low and you've taken progesterone pessaries, your doctor might say, okay, well, I think we need to do the progesterone injections, which are really not very nice injections and painful, but your doctor might think that's best for you.
Perfect, not a problem at all. And Lynn, the other thing I want to ask you about in terms of an IVF cycle is when you recommend or do PGS or PGTA, I think it's now called, for your patients. So pre-implantation genetic screening, is that something that you do routinely, or do you target it based on a particular sort of elements of the patient's history? Yeah, so
I tend to offer it to all patients over 35. So I offer it, I don't say that everyone needs to take it up, but I do offer it, because if you've got, say if a patient has collected, say 4 blastocysts, perfect result, I've got 4 blastocysts, and you're 37, know that probably half those blastocysts aren't going to be normal based on statistics. And so if you put 1 in and it hasn't worked, now you've got 3 in the freezer. So do you then spend the next 3-4 months putting those embryos in, which you do, and still at the end of the time you may not be pregnant, or it might take you another 2 embryos to find the real one, or the right one, I mean, that's going to get you pregnant. So I often do suggest that to women or couples where the woman is over 35 as a good thing. And in fact, they did a study, it was from Colorado, Schoolcraft did a study where they looked at 32-year-olds going through IVF. They had 32-year-olds, which I wouldn't normally recommend that they do embryo testing because their eggs are younger. So they had 2 groups, and the 32-year-olds that tested their embryos were quicker to get pregnant and less likely to miscarry.
Right.
So I think there is, but it's something that you need to discuss as a IVF doctor with your patients carefully.
Absolutely.
So, but I think there is benefit to it. And
fantastic.
Particularly if you've got a lot of embryos to choose from, because you want to get your patients pregnant quickly, and you don't want them to get to 10 weeks and find out they've got something like Down syndrome or something that then they have to decide what they're going to do at that point.
Definitely. Brilliant, Lynn. Fantastic. Well, if you've got sort of 5-10 more minutes, I thought I've had some really good questions from some women who've sent them through to me, and I wouldn't mind asking them to you if that's all right with you. So I've got about 5 questions, if that's all right. So firstly, for single women or same-sex couples having IVF, is it difficult to access sperm, and how does that sort of occur? What's the easiest way for that to happen?
Yeah, it is difficult to access sperm. So they sometimes can find their own sperm donor. Or some clinics will have a sperm bank for them. But it can be difficult because the choice is limited. So particularly in Victoria, a lot of other states can actually import sperm from overseas. But in Victoria, it's very, very difficult to do that because of our legislation. So the amount of sperm available and sperm donors and the choice of sperm donors is very limited in Victoria because of our legislation.
No worries. The next question comes from a woman who asks, I have a low AMH and my husband's sperm has a low normal morphology. What would you do differently in an IVF cycle, specifically for this couple, given their history? So the 2 issues are low AMH and low normal morphology on the semen analysis.
Yeah, because the problem is when you've got low egg numbers, particularly if they're aging eggs, they can be very fragile. So I find that the eggs have fragility as they're getting older. So then you expose that poor egg to ICSI, which is where you're getting the glass propeller and you're injecting it. So often the eggs will shatter.
I see. Difficult combination. It's
a difficult combination. So with a patient like that, I would probably, depending on how bad the morphology is, I would probably still suggest natural insemination first.
Got it.
The good thing about my clinic is that I will offer a free no out-of-pocket cycle if they do have a failed fertilization, because I am a big believer in natural insemination. And so unless it was 100% abnormal forms, I would encourage the couple first to do natural, because I think those aging eggs with the low egg bank are so fragile that sometimes they will just rupture with the ICSI procedure. So it depends how bad the sperm is, but I'll weigh everything up. And also sometimes I'll get a call from the scientists and they say, Dr. Lynn, the sperm's so bad, we have to do ICSI. Well, I have no choice. So
absolutely.
But my first preference for a low AMH and possibly poor egg quality would be natural.
Absolutely. And I suppose that case really highlights that every couple is different, and it's about, seeing a fertility expert who can make those decisions about what needs to be done for each individual case.
And to think, to really think outside the box and not just like, okay, bad sperm means ICSI. It doesn't always mean ICSI.
Absolutely.
On what criteria? When I first started IVF as a specialty, we used to say 85% abnormal forms meant you were infertile. And now that guideline has now shifted to 96%.
Correct. Wow.
So almost everyone 15 years ago was getting ICSI when they only had 85% abnormal forms.
Yep. How interesting. Things have changed.
Yeah.
Definitely. The next question comes from a 32-year-old woman who has PCOS, no other fertility issues, who wants to know what her chance of success with an IVF cycle would be.
Oh, I love polycystic ovary patients. So there you go. You're actually like the best patients. Like,
She'll be very happy to hear that.
yeah, no. So normally with a polycystic ovary patient, yes, you might have the patients who have lots of eggs that have poor quality eggs, but normally IVF for me is all about eggs. The more eggs we can get without getting too many,
Yes.
the more chance that patient has of getting pregnant. And like what we discussed earlier on is 15 eggs might end up with 3 embryos. 20 eggs might end up with 4 or 5 embryos. So polycystic ovary patients do have actually in IVF the highest pregnancy rate. So
Brilliant.
as long as your doctor doses you correctly, doesn't overstimulate you, is very careful, you'll probably be more of the patient that I would recommend that you have an embryo freeze.
Yes.
And then put the embryo in at a later stage, because you really don't want to get hyperstimulation syndrome. The severe form is not nice.
No.
And I think anyone with polycystic ovaries should be encouraged to freeze their embryos.
Fantastic. The next question is from a woman who says, with my first IVF attempt, only 2 follicles were collected. What would you do differently next cycle, or will I always have a low number of eggs collected?
So cycle variation is very common. So you might have 2 eggs one cycle, the next cycle might be 4, the next cycle might go back to 2, or the next cycle you might get something like 10. So cycle variation, so it's important not to give up after your first cycle and just go, I am very defeated, I'm only getting 2 eggs, you know, that's not going to work for me. Cycle variation happens. And remember, those eggs are being recruited 3 months ago. So whatever's coming through 3 months ago might be amazing. You might suddenly get 9 eggs. So I think it's important for your doctor maybe to change the doses, change your treatment. But it's all about cycle variation and what antral follicle pool you have on day 2 when those medications have started.
Fantastic. Excellent. 2 more questions and then I'll let you go because I'm sure you've got a busy week ahead. I've had a couple who've asked, how successful is IUI as an alternative to IVF?
So IUI has a much lower pregnancy rate than IVF. And IUI, you might suggest to a patient at the start of their fertility journey, perhaps IUI might be a good treatment. So that would be at the very start. So at the very start, when a fertility couple comes to see me, we check the fallopian tubes to see if they're open. Is ovulation occurring? Is the sperm working? So that might be a very first option for a patient. The pregnancy rates aren't very high with IUI. They might range from 10 to 15%. Not that great. Whereas IVF, you will have double pregnancy rate compared to that. And IVF, you'll get much more information than an IUI cycle. So yeah, IUI doesn't have great statistics. Same with ovulation induction. But I find when I see patients, as soon as you start talking about fertility treatments, if you mention IVF, it's IVF straight off, then a lot of patients don't like that. So it's almost like they have to have a step ladder approach.
Absolutely.
Ovulation therapy. And we still do get people pregnant. Like with the lipid oil, which is the poppy seed oil and the iodine, which I've been using a lot, we're getting 40% of our patients are getting pregnant within 4 months of having that test. So usually if the sperm's normal, I'll do a tube test with the poppy seed oil or lipid oil. And then within 4 months or so, the patients are either pregnant or not. And those ones that aren't pregnant will move on to IVF.
Perfect. And my last question for you tonight, Lynn, does stress affect an individual's ability to conceive? And do you have any tips for making the whole process less stressful?
Yeah, stress definitely does affect things. I think your mind's very powerful. And particularly, so I have a lot of guys that start saying that they can't perform at the time of ovulation and things like that because they're so stressed. And then the female gets stressed. So I think stress is a very big factor. And even when we're putting the embryo in, if patients are really stressed, I think that can probably affect whether IVF is going to be successful. So it's really difficult to be relaxed and de-stressed when you're on an IVF cycle.
For sure.
I think you need to look for other things that relax you. And it is hard at this time because of coronavirus, because we can't have.
It's really difficult.
Facials.
Absolutely.
Yeah. So I think, you know, meditation tapes.
Yep.
Acupuncture's back on, so patients can access acupuncture. So acupuncture's back on. Meditation tapes, I think, are amazing.
Yep.
And, you know, just trying to practice positive mindfulness and trying to believe that embryo is going to implant is very important as well.
Excellent, Lynn. Well, thank you very, very much for your time tonight. I think it's been a really wonderful talk that I think will really be insightful and enlightening for a lot of couples going through this. It is a very daunting process, I think, for a lot of people to start with, but knowing, you know, that they can have support right through from a fertility expert is really, really brilliant for them. So if anyone who's been watching tonight would like to follow Lynn, Fertility Queen Dr. Burmeister, she's got a brilliant Instagram page as well. And once again, thank you for tonight. I really appreciate it.
Thank you, Scott. Have a
Take
great
care,
week.
Lynn. Have a good night. You too.
Bye.
Take care.
Bye.
Bye. Bye. Bye.
Bye.